Hello, good afternoon. My name is Janet Walsmith, and it is my honor to invite you to attend this Alzheimer's session as part of our Neurological Symposium from the McCourt Foundation. This is actually our 20th annual Neurological Symposium, so we really appreciate you being here. This event really embodies our mission of striving to cure neurological diseases while empowering communities to build a healthier world. We want to say a big thank you to our sponsors. So we appreciate you stepping up to make sure that this event is provided for free for everyone, and also for our nonprofit partners, including the South Shore Conservatory Creative Arts Therapy. We also have the Alzheimer's research team from Brigham and Women's. So please make sure you stop by their booths for all the sponsors in our lobby before or after this session. I also want to thank our partner hospitals, Brigham and Women's Hospital, Massachusetts General Hospital, and Cedars-Sinai for their ongoing collaboration in trying to make a difference. On a personal note, I shared this before the multiple sclerosis session. I was diagnosed with MS a few years ago, and it was a super scary time, as some of you might know if you have a friend or family member, or yourself if you've ever been faced with a health challenge. But I remember not really knowing where to turn. And it was during the height of the pandemic that a friend had sent me the link to what we then called the Educational Update, which is this event. And I was super impressed by what I heard. And I'm a mom, I have 3 kids. And I know during tough times or times of crises, we're kind of encouraged to share with our children to look for the helpers. And that's kind of what I kept thinking. I was like, gosh, there's so many people in this community who are trying to make a difference, find cures, think of treatments that can manage symptoms or stave off the progression of a disease. There's researchers, doctors, obviously working together, volunteers. So that's what I would encourage you today. Hopefully you'll feel a spark like I did. I kind of went from a moment of uncertainty to hopefully empowerment, that I hope for you all that you can have a spark, that you learn some nuggets that you can use in your everyday life that can fuel you in your health journey, or if you're supporting someone else in theirs, so that you can realize that we really can shape our healing journey by empowering ourselves to join community, learn as much as you can, about your disease or other modalities that can improve your overall wellness, and then also connect with others. So hopefully you'll find that today. I really want to thank our presenters, our doctors who are here donating their time for the benefit of us all. So without further ado, I'm going to say a quick word about housekeeping items. If you have questions, thank you first of all, for those who have already submitted their questions when they registered, but more questions are bound to come up. So if you are in the room and you'd like to raise your hand, we have some of our awesome volunteers who are going to come around and they'll give you the mic and you can ask questions real time. If you'd rather submit a question anonymously, you can also write that on the card. You'll see those colored baskets on your tables, green and red. You can put those cards there, and then again, the volunteers will intermittently come around the tables. And finally, if you're tuning in virtually, thank you. You can use the Q&A chat sessions to type in your questions there. And we ask that you reserve those for questions for the presenters to make sure that we can get through as many as possible. So it's my privilege to present our panel. I'm actually going to just introduce Dr. Stern, who is going to be moderating. So we appreciate your stepping up for that. And then he can introduce the rest of the team. Thanks again for being here.
Thank you, everybody. It's an honor to be here. Thank you to the McCourt Foundation and our sponsors, and most importantly, all of you here and online for attending and letting us speak with you. It's a very exciting time in Alzheimer's disease, as you've probably heard in the news. So we'll get into it. I'll start with close friend and colleague, Steve Gompertz from Massachusetts General Hospital. He's an assistant professor of neurology at Harvard Medical School. He did his training at the University of California, San Francisco. And then he came here and is at MGH, where he directs the Lewy Body Center. And he sees patients with movement disorders and memory disorders at Massachusetts General. His research focuses on Parkinson's disease, dementia with Lewy bodies, and Alzheimer's disease. And he's here to talk to you about sleep and Alzheimer's disease. Steve?
Can everyone hear me okay? Well, terrific. It's great to be here and to talk about understanding Alzheimer's disease through the lens of sleep. I have no significant disclosures to make, but do keep busy. And I want to talk about dementia, demographic trends to sort of set the stage for our conversation today. Some 6.5 million Americans have Alzheimer's disease, and this is by far the most common dementia, but not the only one. And dementia increases as we age, with only 1 to 2% of people in America below the age of 65 living with dementia. That number goes up to 1 in 3 above the age of 85. And likewise, incidence, the likelihood of transitioning to dementia, goes up from less than 10 per thousand between the age of 65 to 75 to more than 80 above the age of 85 for Alzheimer's alone. And worldwide, which is what that lower figure shows, the number of people living with dementia is very high, on the order of 50 million people now. And because the population worldwide and in America is aging, those numbers are continuing to increase. So it's a big problem. When we think about Alzheimer's disease, there are 3 major neuropathologic hallmarks. The first are amyloid plaques, which accumulate in the brain outside of brain cells, shown here. The second are neurofibrillary tangles, aggregates of tau inside brain cells, just shown to the left. And together, those are associated with brain cell loss. And those problems accumulate in stereotyped fashion over the lifespan, with amyloid shown in blue accumulating first over many years, decades, then tau accumulating, followed by neurodegeneration, and at some point impacting memory function and ultimately significant functional deficits. It's only when those functional deficits get in the way of our independence that we meet criteria for dementia. But I want to bring our attention to that far left panel, the normal cognition group. This is really where we want to intervene. People that are accumulating amyloid in their brain and tau in their brain, and yet are cognitively normal and living a completely full life. We can look at amyloid in life using amyloid imaging. We can look at tau in life using tau imaging. We can also sample amyloid and tau by looking at the spinal fluid that bathes the brain. And recently, biomarkers have come online for blood tests that allow us to do this too. And this is important because we really want to be able to intervene in life and make sure we're really hitting our targets. Well, how does Alzheimer's disease degrade memory? It's a complicated process, but it looks like amyloid begets tau, and both of these drive loss of brain cells, neuronal loss. Amyloid is very toxic to synapses, the connection between brain cells. And as a result of those 2 processes, synapse toxicity and neuron nerve cell loss, neural circuits that are responsible for brain function, including memory, are impaired. And in Alzheimer's, the very early impairment is one of the memory systems due to failure in the hippocampus, a memory structure of the brain. And that hippocampal system's failure underlies our memory loss. But I want to draw your attention to an arrow that extends from altered excitability to amyloid, because it turns out that altered neural circuit function can, in fact, feed forward to increase brain levels of amyloid. And we've known this now for nearly 20 years. If we increase activity in the brain, we drive the release of amyloid, shown down here. And in this context, it's worth pointing out that amyloid levels actually have a circadian variation. They go up while we're awake and they fall while we're asleep. Part of that might relate to our increased activity during the day, but in fact, the brain is actually quite active at night. So that's not the full explanation. In fact, there are clearance mechanisms that are particularly active in sleep, and that's shown on the far right panel. In green, you can see that clearance of amyloid is quite high in sleep. In orange is actually the much reduced clearance that happens when we're awake. So clearance, this is a bulk flow clearance actually of solutes like amyloid and tau that are really dependent on sleep to work. And interestingly, tau is subject to this very same process. Tau is cleared in sleep. It has a circadian variation as well. And when we're awake, these are in humans, these are in animal models, those levels of soluble tau go up as well. So let's talk about sleep. On the bottom left there, you can see that as we fall asleep, we progress down through cycles, through deeper and deeper slow wave sleep. And then we enter a little stage of sleep called REM in orange. And then that cycle repeats throughout the night. And if we record with our brainwave activity with electrodes over the scalp, it turns out that there are very reliable signature oscillations that occur during this period as we sleep. There are these slow oscillations shown in orange, and there are higher frequency oscillations called spindles, and both in the cortex. And then if you were to listen in on the conversation in the hippocampus, you'd actually, a memory structure, you'd notice a very fast brief oscillation called a hippocampal ripple. And it turns out that there's actually quite a coordination. That ripple coincides with the spindle. That spindle coincides with the slow wave oscillation. These are all nested together. And in fact, that's critical for writing information to disk. We learn new information over the course of the day. That information gets put into our hippocampus for making new memories and coding the new memory, but we have to consolidate it and store it for good in the cortex, and that requires this coordination. Now, as we age, our sleep changes. We take longer to fall asleep. We spend less time asleep, and we're often up during the night with increased awakenings for one reason or another, and our sleep efficiency goes down. That is, the time we spent in bed, the fraction actually asleep. That's what sleep efficiency is. And the amount of time we spend in slow wave sleep also goes down. And it turns out that's important. As sleep quality goes down, as sleep duration goes down, as sleep disturbances go up, spinal fluid measures of Alzheimer's changes actually worsen. And that's true both for amyloid and it's true for tau. And in fact, sleep disturbances at baseline are predictive of greater worsening of brain amyloid over time. So it's not just a matter of quality of sleep affecting our attention the next day, which is absolutely critical and worth keeping in mind, but there's actually a direct link from sleep to these Alzheimer proteins. And in fact, it turns out that for higher levels of tau, shown here, the higher level of tau, the worse the spindles. So tau also degrades spindles, independent of holding the quality of sleep constant. Worse tau makes worse spindles, and we need those spindles to coordinate these brain regions in the service of learning and memory. It turns out that amyloid alone is capable of making this happen, of degrading these nested oscillations. An amyloid animal is shown in red, a normal animal is shown in blue. There's just amyloid, no tau. And you can see that amyloid degrades a slow oscillation, and it degrades the coordination of the spindle with the slow oscillation, and it degrades the coordination of the ripple with the spindle as well. And if we look in REM sleep, where there's another oscillation, a high frequency oscillation called theta up here, and an even higher frequency called gamma that coincides with the peaks of that oscillation. If you look at REM sleep, and it turns out this oscillation exists when we're awake as well, normally we see a high coordination that's shown in orange, and that signal is also lost just with the presence of amyloid. So amyloid is part of the story. Now, sleep affects the longitudinal accumulation of amyloid. Over time, using amyloid PET scans, we can see that amyloid increases. And if we take, as my colleagues, Dr. Weiner and colleagues did, separated people into those with poor slow wave oscillations and those with really good slow oscillations, just assessed with an EEG, a brainwave test. Those with poor slow oscillations accumulated amyloid more quickly over time. Likewise, when they split people into those with the worst sleep efficiency, compared to those with the greatest sleep efficiency, again, those with worse sleep efficiency accumulated amyloid more quickly. So impaired sleep is important, and slow wave activity and sleep efficiency are both risk factors for accumulating amyloid. And therefore, sleep may in fact indicate future Alzheimer's disease and the speed of progression. You can measure brain disorganization using brainwave tests as well, a measure called entropy. And when you do this, it turns out that the state where you measure it, what part of sleep you're in, actually matters. It's really most disorganized in REM sleep in Alzheimer's disease compared to normal people. And the degree of that disorganization actually correlates tightly with how people do on thinking tests. And this becomes potentially a useful measure to as a readout for a drug trial. But I want to turn back to slow waves because amyloid deposits are sensitive to slow waves. Experimentally, if we enhance slow wave activity as shown on the left, we can reduce the amount of amyloid plaques that form. That my colleague Ksenia Kasnenka did this work. And then collaboratively, we showed that experimentally impairing slow wave activity, jamming them, in fact, drives amyloid levels up. The same is true with gamma oscillations. These are those 40 Hertz oscillations that I told you about earlier. This has actually been quite well received in the news. Li Wei-Tsai and colleagues showed first in 2016, and it's been reproduced in several labs, that if you drive the hippocampus, this memory structure, at 40 Hertz, you can reduce amyloid down from normal quite a bit. And if you actually can achieve the same, well, they can achieve the same effect if they stimulate with light. So they flicker light at 40 Hertz, or they add light and sound together at 40 Hertz. And again, they're able to show a reduction of amyloid. It was certainly very exciting, got a fair amount of press. And it seems to be mediated by microglia as well. But there's clearly more to learn. And I say that because just 3 days ago now, a paper came out unable to reproduce the result. And that's the nature of science. We're always looking to see, what's real, what's not. So we'll find out. But there, several studies have reproduced it. One has not, and we'll just have to see what comes. But I should say that on the basis of these observations, human studies are already underway, both phase 1 and phase 2, and now a phase 3 is recruiting, and will soon be moving forward as well. So targeting amyloid, tau, or sleep to interrupt the cycle of sleep brainwave disruption in Alzheimer's disease seems like a good idea. If we can target A beta or tau and reduce those levels, we can restore and rescue circuit function to allow brain wave coordination that we need for learning and memory. And likewise, if we can act to improve sleep, increase our slow waves, and increase our time asleep, we will be able to improve clearance of amyloid and tau, as I've shown you, as well. And those question marks are there because we don't yet have a good understanding of the pharmacology, for example, of the clearance mechanism I've mentioned. But it'll be very exciting to come up with new tools to enhance that. But for now, we have one. We just need to sleep better. And in this context, I want to talk about the fact that sleep is only one of several potentially modifiable risk factors for dementia. These have been identified over the last several years through many epidemiological studies, and they seem to be withstanding the test of time, but few of them have actually undergone placebo-controlled assessments. Nonetheless, they're highly intervenable, actionable items. One is early life education. Less education is a major risk factor for dementia later in life, and we can do something about that. Another is in middle life, hearing loss, hypertension, obesity, alcohol use, excessive alcohol use also. All of these reduce the risk for future dementia. And in later life, smoking, depression, social isolation, physical inactivity, and diabetes. These are all things people above the age of 65 should be working on to reduce our risk for dementia. These are, actionable. And sleep fits definitely into this later life context. We don't yet know whether improving sleep in middle age might be helpful as well, but it might be, given how long it takes for amyloid and tau to accumulate before they disrupt thinking. So just to summarize then, I've shown you today that sleep is a modifiable risk factor for Alzheimer's disease, and a good night's sleep is an important step towards optimized thinking. That's true, of course, as we all know this. If we don't sleep well, we're inattentive, it's hard to make decisions. And this is even more of an issue if we're cognitively impaired. So we want to optimize sleep for that reason alone. But in fact, on top of that, Alzheimer's deposits are cleared in sleep, and impaired sleep disrupts that clearance. Alzheimer's deposits degrade the normal coordination of brain activity and sleep that underlies memory processes. And so targeting sleep and the impaired coordination of brain activity may reduce the risk of dementia or its progression in Alzheimer's disease. So I just want to stop to thank my lab and also my collaborators at the Massachusetts Alzheimer's Disease Research Center, MADRIC. We do have a desk out there today that you're welcome to drop by. We invite participants to come in and be followed in our memory study so we can understand normal aging and pathologic aging, and to plug people into research opportunities so we can beat Alzheimer's and related diseases. And I also want to thank the McCourt Foundation for the opportunity to speak today and for their wonderful support of the Department of Neurology at Mass General. Thank you.
Right. I think we're reserving questions for the end, right? Right. Okay. Okay. Well, thank you, Dr. Comperts. That was terrific. So I'm Andrew Stern. I'm a behavioral neurologist at the Brigham and Women's Hospital. And I am here to speak to you a little bit more about the road to Alzheimer's disease therapy from a bit of a historical lens, and tell you about some of the work we're doing at the Brigham to improve therapy for Alzheimer's disease. Dr. Gompert's already talked about plaques and tangles, which you've probably heard about many times if you've come to one of these symposia educational updates before. But just to reiterate, the black arrow there points to an amyloid plaque, and the red arrow points to a neurofibrillary tangle. And this is what Alzheimer saw under the microscope in the 1910s when he first was describing Alzheimer's disease as it became to be known. And at this was a long time ago. This is before we knew the double helix structure of DNA. Really, all they could do was take dyes and apply them to brain tissue after people passed away. And this is what he saw. And it took a very, very long time before any progress was made in understanding what this stuff, these plaques and tangles, are made of. It took really all the way until the 1980s, after the double helix, for example, was discovered, after we learned what proteins were and what they were made of, that we really understood that plaques, what was pointed to by that arrow, are composed of something called what came to be known as A beta, right? Amyloid beta. And these are some of the paper titles from the 1980s, including from my own mentor, Dennis Selko, there on the bottom, who published one of the papers in 1984 describing this. And this was our first understanding of what the molecule that makes up amyloid plaques is made of. It was called amyloid beta. It's tiny. And on the left there is what we call as an A beta or amyloid beta monomer. So mono meaning one, mer meaning thing. So individual A beta monomers, maybe just a few hundred atoms in size, are released from your cells all throughout your life, including your brain cells. And at some point along the way, they start to clump together. They form what people have been calling there in the middle oligomers. Oligo is Greek for a few, or protofibrils are another term that people have used. And then over time, they aggregate even more and more and more into these large, huge, comparatively structures we call amyloid plaques or A beta plaques. And then they become big enough for us to see, for Alzheimer to have seen it under the microscope. Very tiny, tiny things that aggregate over time into, on the microscopic level, what are quite big. And it was really discovering in the 90s that people who had genetic mutations, so were born with problems in their DNA that led to problems with this A beta, at that time we realized that A beta probably causes Alzheimer's disease, because if you have a genetic mutation, if you're born with a problem in your DNA that leads to problems with A beta, too much of it or having it aggregate too much, then you get Alzheimer's disease. So not surprisingly, we tried to remove the A beta and treat Alzheimer's disease. And this is what people have been trying for decades now, 2000s, 2010s. And pretty much all of the treatments that were tried, they tried to inhibit the release of prevent the release of these A beta molecules into the brain space, tried to remove them with antibodies. It didn't really work. As we probably have, if you've been to one of these symposia before, there have been a lot of trial failures over many years now. And to date, almost all of them, tried to do this, and it didn't work. If you actually take this material from a human brain, or from spinal fluid, from a mouse, what have you, make it in a test tube, and you apply it to a cell in a dish, in a petri dish, the cell does just fine. The amyloid beta monomers, the individual molecules, don't really seem to do all that much to a cell in a dish or to a mouse when you inject it. We learned this along the way at the same time that we were developing failures. So this was not known before these trials were started, but we sort of figured this out as maybe an explanation for why these trials weren't working. The more modern treatments that you've probably heard about in the press, perhaps over the past couple of years, like aducanumab and lecanemab, now that they're FDA approved, they get brand names, Aduhelm and Leqembi. These attempt to remove these other forms of A beta once it's already aggregated into oligomers or perhaps all the way out into plaques, these big amyloid plaques. And when you study this stuff in the lab, when you take this out of a brain of someone who has died from Alzheimer's disease or out of a mouse, and you stick that on some cells, the smaller aggregates, these early aggregates, what we call protofibrils or oligomers, so small aggregates, clumps of A beta, that stuff seems to be toxic. So you apply it to a mouse's brain in a dish or some cells in a dish and they die or they don't function as well as they should. And so maybe that means that the oligomers or protofibrils in our brains, if we're so unlucky to develop them, are what's causing our brain cells to misfire, to degrade, our synapses not to function as well. And so that's potentially a reason for why these treatments are starting to work. And you'll hear about this from our colleague, Dr. Erkinen, who's going to talk in much more detail about lecanemab and aducanumab and the moderate success we've had so far with it. So what is this stuff? You can take it in a dish in a test tube and it seems to cause toxicity to cells in a dish. And maybe it actually does that in the human brain. And maybe getting rid of it with these drugs works. So let's try to figure out in more detail. What are oligomers, fumers? What do they look like? You can't use a regular microscope like Alzheimer did because they're too small, right? You can't just look under the microscope. It's really tiny. But we have other microscopes, not just the ones you look through. This is from an electron microscope. And we and colleagues at the Brigham were able to get some out of the brain tissue of someone who'd passed away and donated their tissue to our research. And we looked under a very, very high-powered microscope called an electron microscope. And this is what we saw. This is what it looked like. This picture, that stick, we call it a fibril, is 10/1 billionths of a yard wide. It's very tiny. But this appears to be the stuff that is in the brain potentially that might cause toxicity to your synapses or one's synapses with Alzheimer's disease. And we look in more detail. We take these antibodies. We took a little bit of lecanemab, Leqembi, a little bit of aducanumab, Aduhelm, and we added it in a dish and looked under this very powerful microscope, and it sticks to them. The black dots there, those black dots are the individual antibody molecules, even smaller than this fibril. And you can still see the stick, the fibril, which is our oligomer or protofibril maybe of amyloid beta. So it really seems like this is maybe the stuff in your brain or one's brain that being treated with Aduhelm or Leqembi is being removed or that might be preventing some degree of cognitive impairment. But we wanted to take it another step further. So this is all well and good. We can look at some detail. We produce these somewhat grainy, admittedly, pictures of our little sticks. But very modern technology, only developed in the past 10 or so years, enables us to look even closer and develop an even finer picture of what this material looks like. And we sent this to our collaborators over in the United Kingdom at the University of Cambridge, Shores Sherris and Michel Goodert. And this is what they found. So this is a cross section. So if you took that stick and sliced it like a baguette and looked down the barrel, this is what they saw. And this is down to the individual atom. So these are two different structures, but down to the individual carbon atoms and hydrogen atoms and oxygen atoms that you know about. This is the structure of the material from the brain of a person who died of Alzheimer's disease and donated their tissue to us that we think lecanemab, Leqembi, or Aduhelm binds to. And we hope that knowing it down to the atom, we can do better. Maybe we can make a lecanemab that binds a little bit better to it. Maybe we can subclassify. Maybe the red one over there is a little more toxic than the blue one. We don't know any of this yet, but we're trying to figure that out. And maybe we can find a drug that only binds to the blue one and not the red one, if that's the one that causes more toxicity. We're working on it. And so we've gone all the way from Alzheimer, looking under the microscope with staining it with dyes. I think it was actually silver that he placed on the brain tissue, to really, amazing new technology that's enabled us to develop new treatments and understand how they work a little bit better. So I'll conclude, since these are short talks and we'll have time for questions after us, the 3 points that the biochemistry, so the development of understanding what proteins are and what makes up these plaques, that really guided us through this work over decades now. It's looking in the lab, what's toxic to a cell or a mouse, what's not, guided us with what to try to target, what to understand, how to develop drugs to treat Alzheimer's disease. Patients who donated their time, their blood, their CSF, their cerebrospinal fluid, and even their tissue after they passed away really were essential to doing this. donors, both of tissue and, financial donors, and sponsors helped us along the way. And of course, there's a lot more to do because, as you'll hear from Dr. Erkkinen, we've only made a small dent, which is the biggest dent we've made in many decades, but is nonetheless somewhere. And there's a lot more to do to get even better. So thank you. I have to introduce Dr. Erkkinen, sorry. This is my boss, Dr. Erkkinen. He was a fellow as well and a trainee at the Brigham and Women's Hospital where I work now. And then he went over to San Francisco to complete his training and was on staff as a behavioral neurologist in San Francisco. And then we recruited him back to the Brigham and Women's Hospital, where he now serves as the clinical director of the Cognitive Behavioral Neurology Division. He's a born and raised New Englander. And he is now the director of our clinic, where he is seeking to make major changes and improvements in the way we deliver care to patients with Alzheimer's disease, especially in the important new era of coordinating care for people who are going to receive these medications, the plaque-removing medications. And so he's going to tell you about the new medications and how we plan to deliver them safely and equitably. Thank you.
Great. Thank you for having me today. So we'll spend our few minutes on advances in anti-amyloid therapeutics. So it's been an eventful year. I'd say the big event in the past few months. In January of 2023, lecanemab was granted accelerated approval by the FDA. I will say upfront, it's not really widely available yet for clinical use. So a lot of what we're going to talk about is sort of thinking ahead as to how we can be ready for that. So, what is lecanemab? Well, mechanistically, as Andrew alluded to, it is a monoclonal antibody that binds amyloid and it removes it. As has been discussed in both talks, amyloid is one of the two hallmark proteins associated with Alzheimer's disease, the other one being tau. And there's an important idea, as has been kind of not explicitly mentioned, but in the ether here, is that the idea of the amyloid hypothesis, that amyloid toxicity is central to the pathophysiology of Alzheimer's disease. So, targeting amyloid, in particular those oligomers that Andrew had mentioned, perhaps is a way to alter the underlying disease itself. As of this time, this is a medicine that is administered IV. But beyond its mechanism, what it really represents is a novel disease-modifying therapy. Most therapies now, Aricept and memantine and others, they target symptoms, but they're not really thought to target the underlying disease itself. And this is really kind of an exciting time because we think these medicine lecanemab targets the underlying disease itself. Most of our, I would say that in the fall, there was a very important phase 3 trial, which is kind of a late stage trial called Clarity AD, and it was published in the New England Journal of Medicine. So again, this is a large double-blind placebo-controlled study. There were about 1,800 patients, half of which received lecanemab, half of which received a placebo. Importantly, this was people with MCI, kind of a very early stage, or mild stages of dementia. This wasn't late stage dementia. Everyone had to have some cognitive testing, what's called an MMSE, or a mini mental status exam, and it had to have some impairment, but not advanced impairment. And importantly here, everyone here had to have a marker of disease, a biological marker of disease, either via an amyloid scan or via a spinal tap that showed, abnormal markers of Alzheimer's disease. And it excluded people who had hemorrhages or bleeding in the brain, which we'll talk about why that was irrelevant in a moment. And the ending readout, this was an 18-month trial. Importantly, as we'll discuss, Alzheimer's disease is not an 18-month illness. It's a many, many years illness. So 18 months is kind of a snapshot as to how these medicines may be working. it's unknown as to what happens when you're in the brains and clinically after 18 months. Okay, so what are the things you might look for to see if a medicine, works? Well, one, does it say what it's, does it do what it's supposed to do? So for folks who received amyloid and those who received the placebo, they had serial amyloid scans over time, and it shows here that those who received lecanemab had much lower rates of amyloid over time. So it does what it says it does. It removes amyloid effectively. That's important, but I think, of course, what you want to know is not only if it removes amyloid, but if it actually improves one's function or one's symptoms. And I think what the primary endpoint was, what the main outcome of interest was does it improve one's function? And the way you measure function in Alzheimer's disease is this thing called the CDR, or the Clinical Dementia Ratings Scale. And this is a semi-structured interview, with families and patients. And it allows you to measure one's function in 6 different domains. So that can be things like your memory, executive functioning, judgment, etc. And you're scored from 0 to 3 on each of those 6 domains. 0 meaning there's no impairment, 1 meaning there's mild impairment, 2 is moderate, and 3 is severe. So a high score of this 18 would be a worse function. And just to kind of so we are aware, mild dementia would be a 1, and MCI would be approximately a 0.5. So these patients enrolled in this study, even though the scale was out of 18, the average baseline score was actually about 3.3, because there were a lot of 1s and 0.5s. And as you can see here, lecanemab shows a slower decline in function compared to a placebo, and those curves are widening throughout the 18 months that it was measured. Of note, the actual absolute number was a 0.45 difference on that 18-point CDR. Okay, and there's a lot of important debates, happening as to whether or not that is it's statistically relevant, but is it a clinically significant difference? Not only did they look at function, they also looked at actual scores on memory and other cognitive tests in this set of paper and pencil tests that's called the ADAS-Cog. And again, people who received lecanemab had slower rates of decline on these cognitive tests, relative to those who didn't receive lecanemab. And then, interestingly, lecanemab also had effects on other markers of disease. So, if you remove amyloid with lecanemab, it also shows a benefit or an impact on tau, which is not necessarily inherently expected, and other markers of neurodegeneration. So this your medicine seems to have an effect not only on, well, come to this thing, it not only removes amyloid effectively, it slows the decline in function and in memory, and it has a positive effect on other markers of disease. And I guess the main question that all of us are talking about and wrestling with is, are these changes clinically significant? And again, are they significant at 18 months? Or if we extrapolate out, if those curves stay widening, will they be significant over the course of 4, 5, 6, 7, 8 years? And these are kind of open questions at this point. Okay, very important is knowing, what are the side effects and the safety issues around lecanemab. Well, most commonly would be an infusion reaction. These are IV medicines, and as the medicine is going in or shortly after, you might feel like you have an infusion reaction, and that can range in severity. And about a quarter of folks on the drug had an infusion reaction. The other important factor here is that actual, the rates of dying, those who died, who received lecanemab or who did not, they were actually equal. They were the same. So there wasn't, at least during the study period, there wasn't an increase in mortality or a death in those who received lecanemab. There's a very important side effect that people are learning about, and it's important that we talk about it here. This thing called ARIA, A-R-I-A. It stands for amyloid-related imaging abnormalities. And as you remove amyloid across the blood vessels, it makes those vessels leaky, and you're apt to have some fluid shift across those leaky vessels, which would cause swelling or edema, and that would be called ARIA-E for edema. And then as you make these vessels leaky, you're apt to have some bleeding as well, and that is, or hemorrhage. So ARIA-H for hemorrhage. And the rates of ARIA-E, you can see below, about 12.5% of folks who received lecanemab had ARIA-E. About 17% of people who received lecanemab had evidence of ARIA-H. About 21% had either ARIA-E or ARIA-H. And importantly, though, those rates seem high, and they are high. That's a significant number of people. The rates of people who actually had symptoms from ARIA were much, much lower. So for ARIA-E was about 3%, and ARIA-H was less than 1%. So these are relatively common, but they're also unlikely to cause symptoms. And the rates of serious side effects were even lower. Importantly, there's a gene that can modulate one's risk for Alzheimer's disease called ApoE. And there's particular one variant of that gene called the epsilon 4 allele. And we also know that in this study, folks who have an epsilon 4 allele of the ApoE4 gene have higher rates of ARIA. So that's important that we recognize, because that may be a test that we want to send when thinking about who's appropriate for this medicine. Good. And just an important note, because it's common as we age to be on things like Coumadin or Eliquis, what are known as anticoagulants or blood thinners. And there was a higher rate of people who had larger bleeds, what are called macrohemorrhages, on folks who were on these blood thinners. And importantly, after the actual study period, in the open label extension, there have been 3 additional deaths reported. One was on anticoagulation, one wasn't, and then one had received a drug to treat stroke called a TPA, which has a bleeding risk associated with it. So, the most common side effect of lecanemab is an infusion reaction. ARIA of any kind occurs in about 20%, almost always asymptomatic, although perhaps those rates of ARIA are higher in folks with ApoE4 alleles. There's a higher risk of macrohemorrhages on people with anticoagulation. And there was no difference in dying when in the study period, but there were these other deaths reported in the open label extension. And then, of course, the big question here is, do the modest benefits that we talked about earlier outweigh these risks? And that's something that is an open question for all of us. So, what are the barriers to access? Well, there are, it's expensive. It's, right now it's $26,000 per year. It's what it's listed for. And as of now, Medicare is not, is restricting coverage to those who are enrolled in a study. Although they're thinking about considering this if the FDA were to change their approval from an accelerated approval to what's called a full approval. And we'll know that sometime in the summer of this year, which would then perhaps, lower the costs for all. There are labor-intensive procedures with this, right? As of now, in Alzheimer's disease, a marker is required for eligibility. So that means that everyone who wants to receive this medicine would either need a spinal tap or an amyloid scan. And amyloid scans, as of now, are not covered by most insurance plans. It's intensive. There's IV infusions every 2 weeks. And this, as of now, at least 18 months and perhaps longer. We don't know exactly what the end point it would be. one would need multiple MRIs to monitor for ARIA over the course of the first 6 or 7 months. And of course, this will likely you roll out first at academic centers, and those aren't everywhere on the map. So there may be some geographic access issues. Of course, there are institutional barriers as well. There's not a endless supply of doctors who have expertise in dementia. And I think there's perhaps a sentiment, at least amongst the folks I've met with, of general neurologists and PCPs not being familiar with these medicines and not necessarily being eager to be the ones to start prescribing right away. Eligibility screening, as we already mentioned, is labor intensive, and that limits our resources we have even at well-resourced hospitals, MRIs, spinal taps, cognitive assessments, etc. And then, of course, your monitoring over time is also resource intensive as well. So I just wanted to update you all as to the efforts that are happening at Mass General Brigham. This is a multi-institutional team of specialists you're working to prepare and build the infrastructure needed to deliver these medicines in the right way. We are defining and developing guidelines and standards for appropriate use and safety monitoring. And we're really designing novel models of care so we can deliver these medicines efficiently. We are in the works of being part of a national registry called the ALZNet, which will collect data on folks who receive this medicine to better understand how they work and how we can improve these medicines over time. Few ideas about where this may be headed in the future. One would be, as of now, this is an IV medicine. Perhaps there's some investigations now looking into a subcutaneous formulation of lecanemab. There are other anti-amyloid therapies that are expected to actually read out in the next few months. One called donanemab. Of course, in the future, there's excitement about using an anti-amyloid therapy with an anti-tau therapy to see if there can be a synergistic effect. And then one of the exciting things that's happening now is Alzheimer's disease prevention studies. So, folks who have, markers of Alzheimer's disease on a scan, but yet who are cognitively normal, to use a medicine like lecanemab in that early stage, if you can actually prevent the onset of symptoms. These are happening now, and there's actually a study that is, based at the Brigham, though it's multi-site, called the AHEAD 345 study. So if anyone is interested in learning about that, we actually have a table with Lenore Jackson Pope, who would be happy to provide you info about the AHEAD 345 study and other studies that we have at our center. Our center is called the Center for Alzheimer's and Research Treatment, also known as McCourt. So I think the progress in the science of clinical AD, of course, comes from the collective efforts of many individuals. Of course, researchers and doctors, philanthropy like the McCourt Foundation, public investment, and of course, this is absolutely critical. Patients and research participants and their families. This would not, all the progress we've made would not be possible without the generosity of our patients and families. So this is a start. There's much more work to do. And as we move from these therapies from the bench to the bedside, there's the ongoing need for philanthropic support has never been any more urgent. So thank you all.
Okay, can you hear me on this mic? Good, it sounds like you can. Well, thank you to Dr. Erkinen and Gompertz. Maybe we should start our question and answer period and find out if there are any live questions from the audience to start. Feel free. Looks like there's one over here.
Sorry, you mentioned depression being an issue like 75 and up, but I feel like I'm starting to hear more comments about depression and anxiety like during your life and taking medications to treat that? Do they have any studies that show that that impacts developing Alzheimer's?
Thanks for the question. The question is about mood and its relationship with Alzheimer's and dementia. Mood, depression in its own right can cause what looks like a dementia, a pseudo dementia. So optimizing mood is really important in its own right, independent of the importance for quality of life and being the fact that depression can impact sleep, which we think is important for Alzheimer's as well, and for our ability to get out, exercise, and so forth, and be socially engaged, important as well. But I think that there is a risk of mood impairment with later life dementia, so it is worth optimizing. There aren't any. The problem is these require long clinical trials, placebo-controlled over a decade or two, to ask whether or not a drug that impacts mood impacts dementia. So there've been lots of attempts to get at it. I think the jury is still out, but there's every reason to optimize mood in any case, in part because of these indirect effects of mood on the Alzheimer's cascade.
I'll just add that Alzheimer's disease, we think of it as a disease of cognition in memory, but it's also a disease of emotion, and it tends to ramp up the emotional system. It turns the gain switch up a little bit on one's emotions. So something that might make you a little bit upset might make you even really upset, or something that makes you a little bit sad, really anxious. That can have the opposite effect. If you might have always been kind of neutral towards your animals or toward others, and now you have this ability to have a deeper connection, but it's often overlooked that Alzheimer's disease often affects the the limbic and emotional systems too. Right.
Great. I have another question for you, Dr. Gompertz. This one came in from, I think, from the online chat. Does it matter how you achieve a good night's sleep, either by using medication or just having better sleep hygiene in terms of, I guess, your risk for Alzheimer's disease? And is it one part of sleep, perhaps REM sleep, that is most important to improve, and how can we do that?
So that's a great question, and these are active research questions. What I will say is studies that have been focused on drugs that drive sleep suggest that actually those are problematic. So the answer is not by creating a drugged, intoxicated sleep. Unfortunately, that doesn't work. So we do need sleep hygiene. We do need to work on the things that are getting us up in the night. Whether it's, often we will get up to urinate more. There are ways to deal with that. There are doctors specialized in that. General practitioners can help with that. But taking away the coffee after 2 p.m., all the sources of caffeine, straightforward sleep hygiene approaches make a real difference. And to the second question of the stage of sleep to go after, that's really an active question. We know that slow wave sleep, insofar as it's associated with slow waves that drive reduction of amyloid, it appears in longitudinal studies, seems like an important stage of sleep to try to increase. But REM sleep's important too. That's the part where we actively dream. And in animals, if we impair REM sleep or slow wave sleep, we can impair making memories.
Great, thank you. We have another live question here.
Hi, my question is, and I was 2 minutes late, so I don't know if it might have been mentioned, the correlation between what you're presenting now and the HAB study. Like, what is it that's coming out of the HAB study that informs what you're doing now?
Sure. Dr. Erkman, heart aging brain study? I can take it. So HAB study, I don't think any of us is directly involved in, but is centered at the Brigham and is headed up by Risa Sperling, one of our close colleagues, and the Harvard Aging Brain Study. It's called HABS, which was a study of older folks with no symptoms, I don't know if they had to have amyloid at the beginning. I think not. And so who just enrolled as an observational cohort, and they got all amyloid PET scans to see how much amyloid they have, blood tests, cerebrospinal fluid tests. And that's one of several studies, maybe one of the biggest ones here in Boston, but also around the country, of people who are not necessarily being studied for drug trials. For example, like you saw the Clarity study was trying, we're going to give them lecanemab, we're going to give them placebo. This is just observing folks who donate their time, their blood, their cerebrospinal fluid, to get brain scans, to really just understand in more detail, how does Alzheimer's disease change over time, right? That's sort of one of the studies that we really learned that amyloid plaques accumulate in the brain many, many years before people develop symptoms. Nobody knew that until the last 10, 20 years. And HABs, among others, is one of the studies that proved that. And so people who are enrolled in HABs can then maybe also enroll in a drug study where they're really trying to decide, does this drug work better than that drug? They're complementary. We have another question here, is live as well. Sure.
Do you anticipate patent structure and government structure impacting costs of this new Alzheimer's drug for America? I see all those other drugs that are enormously expensive.
Yeah.
So
I can take that one in a little bit. So it's complicated, obviously. So that's the list price. Oh, sorry. Yes. Sorry, I should repeat the question. The question is about whether the way, I guess maybe I'll paraphrase, the way that we pay for drugs in the United States is going to change because of these new medications, or will change in order to make it more affordable. Is that right?
yeah, I mean, it's not just the best. It's very,
Yeah.
yeah.
So yeah, I mean, these companies invest a lot of money and they price their drug based on how much they expect to make off of it. And I guess what's important is, the price for the average American who wants to receive it. We have to remember that the vast majority of people who have Alzheimer's disease are over 65 and are on Medicare. And so Medicare is sort of the big question. Are they going to pay $26,500? As you may know, Medicare is statutorily not allowed to negotiate drug prices. I don't want to get too political, but that may change. It's starting to change, I think, with the newest Inflation Reduction Act from the Biden administration. I've heard through the news maybe that even more so, that Medicare will negotiate its drug prices. For the time being, Medicare, for right now, will essentially not pay for the drug. If, as Dr. Erkinen mentioned, if the FDA gives lecanemab its full blessing, its full approval, we don't have to discuss the details between accelerated and full, then Medicare will sort of they'll pay for it for people who enroll in some sort of research studies. And these are not, very intensive research studies necessarily. It might be as little as giving your name and, address and, sharing your MRI data, your clinical data with a big data bank, so that, we can keep track of everybody. And so Medicare may require that. So participation in a large registry in order to pay for the drug. We don't know for sure. That's what they're saying for the time being. And so if that's true, then the cost will be whatever any other medication that Medicare pays for would be. I probably would depend on your particular Medicare insurance. I will say that we're sort of in uncharted territory a little bit. So, the first drug to come out in this family, Aduhelm, caused a big stir. You guys probably remember it if you're in tune with the news here, because it was much less straightforward. It was much less obvious that it really worked, Aduhelm, compared to Leqembi. And because of that, Medicare, justifiably, was a little unsure if they wanted to pay for a drug that we didn't even really know made any difference. And so they issued what's called the National Coverage Determination, NCD. Normally, Medicare insurance decisions are made locally, sort of by your local insurance that contracts with Medicare. But in this case, for the first time in history, Medicare issued a national coverage determination, which made the decision on behalf of all Medicare insurances. They said, we are just not going to cover it. And that national coverage determination is still in effect. And they've updated it such that it'll change to this, registry study approval if the next drug comes out. So we're hopeful that they'll listen to the data like we have, and I believe at least that there is some evidence that this drug should be used for the right patient in the right time, and that Medicare will be less restrictive in their coverage. I hope that sort of answers your question. I don't know if it really does. Yeah. Go ahead. Yeah.
I just wanted to add
Oh,
quickly.
please. Yeah.
More research will be required to find out whether the treatment needs to be long-term, or whether you can have drug holidays for a little while before you repeat your treatment. And meanwhile, as we heard from Dr. Erkinen, there's real effort to come up with less expensive solutions. For example, a subcutaneous version that doesn't require IV infusion centers as well, that also might have less of this complexity with the ARIA phenomenon. It looks like that might reduce the risk, we think. So much more to come in a very complicated, interesting situation. But it's wonderful to have this problem, to have a drug that seems to actually move the bar a little. And we'd all like to move the bar more, and that there might be a subpopulation of people where it really does. And so we'll be learning more as the days come.
That was actually one of the questions here that came in online was, can you explain why lecanemab is given intravenously? And are there other delivery systems in the works? So I guess that sort of answers it. It's given intravenously because this is a really big molecule. It's not like a tiny little drug like aspirin. We're talking about the atomic scale, so it's not this big. It's thousands of atoms instead of, maybe 10 or 20. And so for that reason, it's kind of hard for the body to absorb it. And, for example, it could never be given as a pill because it wouldn't get across your stomach, your intestines. And even then, after the body's absorbed it into the bloodstream, it's hard for it to get into the brain because there's something called blood-brain barrier, where only a small percentage actually gets from the bloodstream into the brain where it's needed. So that's the easiest way to get it into the bloodstream, is to inject it directly into the bloodstream, obviously, and that's why it's given intravenously. But, bioengineers have come up with ways to package it in a way that it can be given maybe under the skin subcutaneously. And so that's in the works from Biogen, and we don't know, or Eisai, so we don't really know if it's going to work the same or not. But fingers crossed, hopefully we'll have something that works just as well as the intravenous one that can just be given under the skin. But that one's sort of in the works. There's unfortunately never going to be an oral formulation of this drug. Yeah. Yes, please.
Thank you for being here, gentlemen. Regarding the sleep issue, regarding Alzheimer's, what about naps, please? Some people do have difficulty sleeping at night, so then they end up taking a nap. Now, would that be helpful? Thank you.
Absolutely. I think naps are restorative. So for those of us who aren't getting enough sleep, we need those naps to re-energize, and that's going to help us function in the real world in real time. It's going to improve our attention, our ability to multitask, parse a complicated conversation. It's all the more of an issue when we have cognitive impairment, and we're all the more susceptible to sleep deprivation and anything that can sort of tip us over. We're just much more vulnerable if we have mild cognitive impairment, and all the more so with a full-blown dementia from Alzheimer's or anything else. So naps are wonderful. I'm a big fan, but the money should be on trying to optimize sleep to begin with, and then use naps as a catch-up as need be. What we don't want is napping throughout the day and then not being sleepy at night, and then you have this whole circadian reversal, which is quite problematic for a number of reasons, including perhaps with the Alzheimer's biomarker accumulation risk too.
Good. Back there.
Yes, my question is on during those 18 months, how many times did they get that IV injection?
Yeah, it was exactly the number. It was every 2 weeks. So I have to do the math to know exactly what the number was, but it was every 2 weeks. So a lot of injections.
34 times, I think is what that works out to.
Right.
30.
Many injections, or infusions.
Once the leakage start, did it stop or did it continue?
Yeah, that's a great question. ARIA, the leakage of the blood vessels, you're much more apt to have that early on. So early dosing, that's when your risk of getting ARIA is much higher. It was much lower 6 months, 8 months, 10 months, and a year. So it's the highest risk is in the early infusion, and perhaps that's because there's a lot more amyloid. So this is a kind of a speculation, but you're pulling off amyloid at a higher rate. Those vessels are more apt to be even leakier.
Good. I think there was a question here.
Do I understand from your studies that a person who gets a good night's sleep is almost never gets Alzheimer's?
I wish I could say that were the case, but no. Sleep is one of several tools we have in our arsenal to reduce our risk of Alzheimer's, but by no means is it going to completely prevent the disease. It's just one way we can improve our odds by removing the amyloid and tau from the brain, perhaps by reducing the buildup in the process. It's one of these preventable risks of dementia. And if all told of those 12 items that I mentioned as preventable items for dementia, all summers, the expectation is that worldwide we could reduce dementia by 40% if we can go after these preventable, these highly intervenable features. For example, high blood pressure and diabetes and obesity, all altogether increase our risk for cardiovascular, neurovascular risk, and cholesterol gumming up the works of our blood vessels that feed our body and our brain is really a problematic and highly preventable contributor to trouble thinking. If our brain can't get oxygen well, if the blood vessels aren't perfusing the brain well, we're not going to think well. So going after that, that set of preventable features, I think, is very important, but they aren't the whole answer. For example, we touched upon this apolipoprotein E4 gene that some of us just happen to harbor. There are other common mutations that some of us just happen to have that we're living with. They might increase our risk of Alzheimer's disease later in life, and we want to mitigate that risk as best we can.
Maybe we can, I'm not texting, I have questions that were submitted in advance here, and maybe we can take one related to that, is asking about genetics in Alzheimer's disease. Maybe Dr. Erkinen, the questions are, are there any updates on Alzheimer's disease genetics? What is the Alzheimer's gene, if there are any? And how do we measure that or figure it out?
Yeah, right. So that's a great question. So it's a complicated area. If you have a first degree relative with Alzheimer's disease, you're at higher risk of having Alzheimer's disease. So there's an inherited risk that tends to run in families a little bit. There's another gene that's well known that we've been alluding to called the ApoE gene, and it comes with different variants. You get one copy from mom and one copy from the dad, and the variants in the population are ApoE2, ApoE3, and ApoE4. ApoE3 provides you a normal risk of having Alzheimer's disease. ApoE4 is the one that gives you a higher risk. So if you have one copy of ApoE4, you're at a higher risk. If you have two copies, you're at a much higher risk. It's important to know that ApoE and ApoE4 it doesn't mean you're going to get Alzheimer's. It just raises your risk. So there's many people with ApoE4 that never will get Alzheimer's disease, and there's many people who don't have ApoE4 that will. So it's a risk modulation gene. It's not a deterministic one. In fact, I don't routinely screen for it, just in part because I think people can be falsely reassured, or they can be falsely, worried, or be overly worried because it's not a deterministic gene. There's another set of genes that are what are called autosomal dominant. If you have a copy of one of these genes, it's very likely that you will get Alzheimer's disease, and it tends to be a very early age of onset, 40s, 50s, and 60s. But those are much, much, much more rare than the ApoE4 allele. And that tends to be very strongly running in families that you would perhaps know your risk a little bit just by knowing who your family is. Those are much, much, rarer. Right.
Do you mind saying how rare, what percentage of Alzheimer's disease in the world is due to these rare mutations where everybody in the family gets it?
I don't have the exact number, but I think it's got to be less than 2 or 3%. Again, you might know, Andrew. If you, yeah,
I think it's even less than 1%.
Right. It's very, very low. The odds of these autosomal dominant genes.
And those are all genes that affect the production of amyloid, the molecule beta amyloid that we were talking about, for one reason or another, which is interesting. And just to close the thought, there are other common mutations in genes that we're learning about lately. One of them is called TREM2, which brings up, it's a molecule that's on our microglia, which play a role in our defenses, our immune defenses. There's an immune cell in the brain. And it sort of brings up a topic that didn't come up today, that immune cells play a real role in this disease. Inflammation plays a real role in this disease. And there are some pretty exciting efforts afoot to understand that link and to intervene at the level of brain inflammation as well.
Do you know of any drug trials? I actually don't, but curious. That was one of the questions here about, reducing chronic inflammation in the brain and how that might lead to plaques and tangles. And are there any people trying to reduce the inflammation with drugs, for example? Do you know?
So there are varied attempts to get at inflammation, but nothing yet focusing on a molecule linked to Alzheimer's, like a TREM2 focused therapeutic per se. With a question like how do we manage chronic inflammation, I think if it's arising through, say, rheumatoid arthritis, we have to treat the rheumatoid arthritis. If it's arising in a different disease, Crohn's, we need to treat the Crohn's. But there are molecules that are in trials to reduce focused inflammation, including related to the diabetes pathway. with a thought that perhaps this will reduce Alzheimer's disease incidence.
Great. Is there a question there? Or here, sorry, go ahead.
Yes, this is pertaining to the research going on as far as the sleep and the circadian rhythms. I'm just wondering, with the last trial you mentioned, the phase 3, what was it, lecanemab? Do they look at the effectiveness of the drug as it's administered certain times a day? I know I read something within the past year that said there's a lot more emphasis on administering these drugs at night, given the way the body works.
It's a good question. I don't think that I don't think that they restricted administration to a certain time of day. These are given at outpatient infusion centers, and in this case, research infusion centers. You probably book your appointment between the hours of 9 and 5, and it could probably be any time. I doubt, well, it would probably never be given at night because that's when the centers are open. But I doubt it would make a huge difference, whether it was given at 9 a.m. or 4:30 p.m. just because, the body slowly absorbs the drug and it comes up and down, and not necessarily like you give the drug and then it goes away, then you give the drug and it goes away. So, but maybe not. I mean, who knows? So something we can certainly study as the drug gets used more and more. We can ask, do people who get it in the morning do better or worse than the people who get it in the afternoon? Yeah, sure.
But I think that's right. The half-life of the drug is longer than the circadian cycle, so the drug's going to be around throughout, sleep and wake. We think, but we'll learn more.
Probably, yeah. I have a question from the online chat, which I can take, which is, should we use atrial appendage closure devices on patients with ARIA who need anticoagulation? Or maybe you and I can take, this is a very specific and complex clinical question, and to sort of, to clarify, a very common condition many of you have heard of is atrial fibrillation, or AFib. It's a heart rhythm that puts you at risk for stroke. And the way you prevent stroke and atrial fibrillation, AFib, is by you go on blood thinners. You've probably heard them, Eliquis, the ads for it on TV, and Xarelto, and Coumadin was an older drug that fewer people are on. Those drugs might put you at risk of, bleeding in the brain, right, from ARIA, from these drugs. And so what do we do for people who need to be on the blood thinners and maybe get ARIA? So the one way potentially to do that is through a non-invasive surgery where they actually close off a part of the heart where the blood clots form, called the atrial appendage. And so should we do that for people who, have AFib and are going to get ARIA, so that they can go off their blood thinners and then continue on the drug? I mean, this is going to come up. There's, AFib is super common, and Alzheimer's disease, unfortunately, is very common too. And so this clinical question is going to come up, and we don't have an answer right now because we haven't even started using the drug. My guess is that, we will do that if a person is healthy enough to undergo this non-invasive surgery and they really need to be on the blood thinner, and we obviously really want them to be if it goes, they're really a good candidate for lecanemab, then we probably would do something like that. I don't know, Doctor, what do you think?
Right. It's a really great question. It's a complicated area here that is still undefined. We don't know exactly what the standard approach will be to this situation, but it will come up early and often. And I think, particularly as we're learning more that the risk of ARIA perhaps is higher in the first few months, there may be a way where you could sort of, again, the daily risk of a stroke in someone off anticoagulants with atrial fibrillation is relatively low, that there may be some sort of risk benefit analysis of I'm off the anticoagulant for the first few months of therapy. Perhaps I take that risk of having a stroke, but I lower my risk of having ARIA, right? There's a complex decision-making process here that I think needs to be defined, particularly with individuals in assessing their risk.
Hi, thank you so much. I have two quick questions. Well, one is quicker than the other. So this is just a simple yes or no question. I work a lot with individuals with Down syndrome, and I've noticed, and I think there's research to cite that they're more likely to develop Alzheimer's and different dementias. And I'm wondering if that's still because of that 1980 study that said they have more amyloid production. Is that true?
Yes,
Okay.
I'll give you more than one word if that's
Okay.
okay. So people with Down syndrome are at very, very high risk of having Alzheimer's disease, and they typically develop symptoms in their 40s or 50s. And as you may know, Down syndrome is due to having an extra copy of chromosome 21. So we all have, 23 chromosomes and 2 copies of each. And if you get a third copy of chromosome 21, you get Down syndrome. And the gene there's one gene on chromosome 21 called amyloid precursor protein, which gives rise to amyloid beta. And so people with Down syndrome have 1.5 times as much A beta being produced all throughout their lives. And for that reason, they develop Alzheimer's disease at much higher rates than people who don't have Down syndrome.
Thank you. And my other question was, I was just thinking about the 12 steps that you can take to help prevent the onset of Alzheimer's, or like factors that influence whether you're going to get Alzheimer's. And I was thinking about like traditionally underrepresented populations and how they tend to have higher frequency of Alzheimer's and dementias, and also women. And I've always thought, using women as an example, well, they live longer, so maybe that's why their prevalence of Alzheimer's is higher. But I'm also thinking about like the difference generationally between my grandmother, no education, my mother, bachelor's, me, master's, and like how the generation that has the Alzheimer's right now is like my grandmother, and they were trailblazers if they had education and things like that. So I'm wondering if the reason why these populations have higher prevalence of Alzheimer's is because they didn't have access to education, or if they weren't educated, maybe they couldn't exercise a lot, or maybe they were like in the house or what have you. So I'm just wondering how much of it is like biological versus the environmental factors like that.
That's a really tough question to answer, but you're right. The dementia rates are on average declining with time. Not a lot, because it's still obviously an enormous problem. They may increase again as the population continues to age, but because people became more educated, they stopped smoking and they exercise more frequently, is that the cause? And it may very well be. It's not clear that that all those factors have reduced the numbers of plaques and tangles in the brains of people who have gotten older, but it certainly has reduced the atherosclerosis, the buildup in the blood vessels in the brain, for example, that can cause problems with thinking and memory, and makes the plaques and the tangles affect the brain more severely. So you're probably right that the trailblazing of your mother and grandmother have helped in some way pass on some improvements in memory outcomes for their children and grandchildren.
I would
Dr.
agree
Gompertz?
with that. So although the incidence of dementia is falling in America in older adults compared to their parents, that's not true with respect to underrepresented minorities. So that's actually where it's still increasing, and it's also increasing faster, of course, in the third world as well. And part of that, I do think, reflects inadequate access to resources. So part of it reflects the fact that underrepresented minorities in America today are not getting adequate medical treatment for their blood pressure. They tend to be overweight with inadequate resources, access to good food and good nutrition. They're therefore at risk for diabetes and the vascular risk. So these are highly intervenable, actionable items. But I absolutely agree that it's important to emphasize that those 12 items, and there are a few more we're thinking about that are also relevant. Turns out that pollution is also a risk factor, pollution in midlife. For future dementia. Those are all risks for dementia, by not necessarily Alzheimer's. Alzheimer's is the most common dementia, but by dementia, we mean a progressive cognitive impairment that results in our lack of independence in our functional activities. It's not only Alzheimer's that causes that, it's vascular disease, it's Lewy body disease, and other things too. Okay.
Thank you. Thank you all excellent teachers, very, very great educators. My question kind of relates to a lot of things that's been said. It's about stress. I missed the 12 the 12 protective factors that you when I came in. But I did hear some of the modifiable factors. And I was thinking about stress specifically, and chronic stress. This also could relate to our elders who had much more challenging lives than we have. And then the inflammation, like cortisol. We know cortisol is released when we're under like a lot of stress. And what about chronic stress? Is that something we can put in that little pocket of things that we can do to help ourselves and our brains?
I would say we certainly should optimize our stress. There isn't a direct link from stress to Alzheimer's, but stress via cortisol and other molecules can lead to high blood pressure, can lead to vascular disease on that basis. And when we're anxious, just like when we're depressed, we can be inattentive in a conversation. Someone says something and we didn't write it to disk. We didn't include that information, and later we, hit ourselves over the head. Oh my gosh, my memory's failing. Well, we were inattentive, maybe because we're anxious about something completely different. And optimizing anxiety and stress is really important to be able to function optimally from a thinking perspective. Other thoughts?
Yeah, I think there are there may be some studies, at least in animals, that do link high levels of chronic social stress with some changes in the hippocampus. I don't know if that, I don't think that necessarily correlates with, I actually don't know if it correlates with sort of AD, your markers, amyloid and tau and things like that. But I agree that stress is perhaps a physiological marker of a lot of these other factors, or raises your risk of these other factors that then we know are modifiable. Perhaps stress is a common, link underlying all of those.
There was also a question here about exercise, more specifically, is walking the cure for Alzheimer's, or at least the prevention pill for Alzheimer's disease? Can you guys talk about exercise specifically?
So it's certainly been under a fair amount of study, and it's an exciting, again, highly intervenable tool that we have in our arsenal. There have been a number of studies. Most of them are unfortunately retrospective, but there are really some clever clinical studies that try to assess whether exercise compared to non-exercise or different kinds of exercise lead to benefit over time. What we want. Unfortunately, it's very hard to placebo control. It's not a placebo-controlled trial, but you can do a clinical trial and look for benefit. It does look like there is improvement in thinking associated with exercise. The data are pretty robust. And there seems to be a sweet spot somewhere around 8,000 steps a day, I think, 4,000 steps a day, if I remember correctly, which is a lot. But I think as doctors, all of us will take whatever we can get. I think that exercise can absolutely help, and it's going to help it probably quite indirectly by reducing weight and helping neurovascular health in that way. It's also good for mood, and it's actually good for sleep. We're going to sleep better when we exercise well. But interestingly, exercise also, and this is kind of cutting edge research, exercise also induces molecules that are made in the muscle, in the skeletal muscle, that then travel to the brain and can have direct effects there as well. Something called irisin is one of them. There are a few such molecules it's really interesting stuff. But yeah, I do think exercise is every reason to do it. There's really no reason not to. And it can help in a variety of different contexts. It can help with motor function and Parkinson's disease as well. So I'm a huge fan.
I might add, there's one unfortunately named study from Finland called the FINGERS study. Don't ask me what it stands for, other than the FIN is for Finland. And this is now famous because they combined all these things, right? They combined exercise, speech pathology, physical therapy. There were a few others, and they developed this very intensive program where people with either mild cognitive impairment or mild dementia met with all these people and had very aggressive behavioral intervention. And the improvement was just as good as the drug lecanemab, I think, in terms of improving outcomes. So how can we do that for our patients? And I want, this is a question for Dr. Erkinen, is how can we improve care for our patients other than just showing up to the neurologist to get your half hour and be gone, to do all these things, get people moving and sleeping and thinking better?
I think making a diagnosis of Alzheimer's disease early is important. I think just in seeing a lot of patients, there can be a sense of hopelessness that this happened to me and there's nothing I can do about it. I have many patients come into my office and say, okay, I have Alzheimer's disease. There's nothing I can do. And I think the science doesn't support that there is a lot you can do. And I think the fact that there's some element of self-ownership over the outcomes of this disease, and I don't want to overemphasize it. You can't necessarily cure oneself, but you can bend the curve. I think that's very, very empowering for patients to know that is true. The science supports that. Exercise, eating well, eating a Mediterranean diet, sleeping well, staying active in your mind, being around family and friends and loved ones and having those close relationships. Those are all supported and can bend the curve. And I think I'm glad that there are studies like the FINGER study that can sort of provide us evidence, but sort of we all know just from seeing a lot of patients that these are all very much therapeutic interventions. So to me, I think, how can we do that? I think it's, perhaps sometimes the diagnosis of Alzheimer's disease or having a family member with Alzheimer's disease can provide that extra sense of urgency and motivation and drive, even in midlife. Right.
Is there more from the audience?
My question is regarding diet. How does that affect, or what are your recommendations?
Yeah, right. I think there's the probably the best supported dietary intervention is just a Mediterranean style diet. Usually we say what's good for your heart is good for your brain. Perhaps the vessels are the same; they come from the heart. So I think a Mediterranean style diet. Fresh fruits, fresh veggies. If you eat meat, eat fish, not a lot of red meat. Nuts and oils, as opposed to saturated fats and sort of salty snacks, those things should be avoided. So kind of a Mediterranean style diet, I think has the best evidence. There's a lot of interest in other diets, but I don't think any of those have risen to the standard we need to make that as a recommendation. So I would say Mediterranean style diet. Yep.
I have another question. I'm going to keep you going, Dr. Erkin, from pre-submitted. How do you differentiate between long COVID symptoms that affect memory and Alzheimer's disease?
Right, there's a lot. So in terms of the way the patient experiences, there can be a lot of overlap. People can have memory loss, slowing of processing, etc. I think one way that can be helpful in terms of in thinking about diagnostics is doing what's called formal neuropsychological testing. And the most common pattern we see for long COVID, at least in the patients I've seen, is what's called executive dysfunction or inattention. And that's sort of the pattern that we see. And that can sometimes happen in Alzheimer's disease, but there are usually other domains of cognition involved, especially episodic memory. And there's a way that we can assess episodic memory on this testing that can help differentiate the type of memory loss you see with Alzheimer's from the type of memory loss you might see from a long COVID.
Just one more question. Do you ever foresee America or Boston or Massachusetts in general ever emulating these places like Finland and the Netherlands where doctors would prescribe music therapy, art therapy, dance therapy? I'm a music therapist, so I'm hoping the answer is yes. And a trip to a museum, like a gym membership, outside of these amazing medications and drugs treatments, because like you were saying, it could be just as effective as medication to get moving and get your brain active. So I know that's kind of like still viewed as this alternative thing, but it could be fully entrenched in the way we provide care. I don't know if that's something MGH thinks about or you think could change in our country.
Well, it's not one or the other. I mean, you can do both, right? And
Right.
so what you're asking is not so much can we prescribe it, but will your insurance pay for it? And so, yeah.
It's horrible how it does.
Yeah. Call your congressman. Yeah, I'm with you. It would be wonderful if we had the ability to integrate this into care. And in Medicare accounts, sometimes we rely on philanthropy, honestly, to help us set up programs like art therapy and music therapy and these things, and to have the people who are experts in these fields help our patients. Any more thoughts?
Maybe you can write a letter with me.
Sure.
So I completely agree. And I would just add that I do prescribe exercise. I don't specify what I'm demanding of my patients to do, but if they're agreeable, I will prescribe exercise in broad form.
I'll just add there's interest at the Brigham in starting, it's not launched yet, but interest in starting a brain health clinic where either at risk or just healthy midlife adults come in and get sort of a brain health consultation as to how to sort of ward off symptoms of Alzheimer's disease or other dementias later in life. That's not here, but I do think there's a lot of excitement and interest in this as we're learning more and more about the science.
Although to be fair, that is here at Mass General. So we do have a brain health clinic already up and running for people who are just want a consultation to help optimize their function in midlife for plans for later life.
other questions? I think we have like one or two more here. There's a question, we talk a lot about amyloid plaques, but in comparison to symptomatic therapies, but the symptoms of Alzheimer's are, what cause us the most distress. And so there's a question pre-submitted about any new medications in the pipeline coming through for psychiatric symptoms in Alzheimer's disease, anxiety, agitation, wanting to go home all the time when you're already at home, which is a very common symptom. I'll start with Dr. Erkinen. Do you know of any new interventions for that?
It's very, as we mentioned earlier, it's very, very common to have emotional changes in Alzheimer's disease and other dementia. So it's common to use medications. We typically start with something, we typically start with something like Aricept, which is a cholinesterase inhibitor that can not only help your memory, it can also sometimes help with the neuropsychiatric symptoms of Alzheimer's disease. We sometimes add memantine, which has a similar kind of benefit on both the cognitive and the neuropsychiatric symptoms. We also may add SSRIs or serotonin reuptake inhibitors that can then kind of help to target aspects of the neuropsychiatric symptoms. We try to avoid a neuroleptic or antipsychotic medications as much as we possibly can, but there are times, perhaps later, at later stages of the illness where a person may become so agitated where they are a threat to themselves or others' health and well-being. And there are medicines that we sometimes use in the sort of antipsychotic class. I believe there's interest actively ongoing in trying to find safer antipsychotic medications. I don't know of any specifically. I think actually Biogen may have one that is either approaching its outcomes or just did, but I don't have that off the top of my head. Yeah.
Good.
And I would just add that, I think we do use medicines when we have to, as Dr. Erkinen said, but we certainly prefer not to. We use these medicines, donepezil and memantine, focus on thinking already. We use the SSRIs focused on anxiety and mood, and we certainly will have a low threshold for using that for agitation. But some of these sort of bigger guns that come with risk, we really try to avoid those. We really prefer using non-pharmaceutical therapy. And there are a lot of interventions that can be quite helpful, just redirection strategies to help our patients. There, music can play quite a nice role as well. Sleep-wake cycle optimization, keeping the lights bright around dusk, things like that. But if we do have to turn to medicine, we certainly will. The other medicine that crossed my mind is dextromethorphan, quinidine, a combination that seems to have some value for some patients as well. But we just have to really be careful to avoid the medicines that, while potentially quite effective, these antipsychotics could be some with a real risk of increased mortality.
You talk about the importance of a good night's sleep. Is there a higher incidence of people developing Alzheimer's that maybe work at night and sleep during the day?
That's a great question. I don't know of any epidemiological studies on that particular question, but I know that people who work at night are at risk for significant mood disorders with their circadian disruption. But I'm going to go back and dig through resources and find the answer to that question. So stay tuned.
One more quick question, I guess.
Sure.
So what should I do? So my mother passed away in August and she was diagnosed with Alzheimer's. She definitely had it. She had the MRIs and had a doctor at Brigham and Women's. My uncle now has been diagnosed with it. Another aunt in Ireland had vascular dementia. So should I just, lose weight, which I'm trying to do, and sleep better? Or should I actually go somewhere and get diagnosed and do an MRI to see if I'm in early stages so I could be on one of these medications?
Right. So I'm sorry to hear about your mother's passing. I think right now, this is important. I think right now, as we've been alluding to, it would be working on those modifiable factors, controlling managing your systemic medical health issues and engaging in these healthy lifestyle habits that we've mentioned. And I think if there's interest in learning about your risk, in particular, participating in a research study where you sort of think about you may, if you're eligible for these studies, to receive one of these anti-amyloid therapies before the onset of symptoms, you could enroll in something like that, where they would often do an MRI and a PET scan and things like that. It's a big commitment to be in a research study, but if that's of interest, there's studies happening now. Yeah.
Good. We're running low on time, or are we okay? We're okay. There's one question which we'll finish up on because it's a good one. Will we have the cure for Alzheimer's disease in the next 5 years? I think the answer is probably no, but I think that we're making progress, and the cure for Alzheimer's disease, I think, won't come overnight. It's going to come in increments, slowly but surely. We'll chip away. It's kind of like football. It's a game of inches. And I think we've sort of made our first down in a long time here, for those of you who are football fans. So we'll get there eventually, and we're not going to stop. Anything else? Good. Okay.
I would agree with that. No, I don't think we're going to have the cure in 5 years, but we've learned so much. The fact that we can intervene on amyloid and see a dent in the disease really means that this hypothesis was right. This idea that amyloid is critical for the disease is correct. And that means that we can use that information to guide further interventions, but perhaps, as Dr. Erkin described earlier in the presentation, by a two-pronged attack, amyloid and tau, or amyloid and tau and neuroinflammation, layering on treatments that make a dent, that make sense from what we understand about the disease, is, I think, going to get us there.
Okay. Thank you all so much.